Well, first of all, Anne, thank you so very much for the invite to be with you all today. It's quite an honor. If a year ago, if you would have told me I would have been presenting here with you today, I wouldn't have believed it. For everyone, I had an MPN and then I had a stem cell transplant 10 months ago. So this is just absolutely just the highest honor to be with you all today. And what I'm going to talk about is sexual health in women with an MPN. And basically, as a gynecologist, I see a lot of sexual dysfunction among patients, whether they have cancer or specifically an MPN, and that's what I'm going to address today. I have no financial disclosures. What we're going to touch on today are three main things. What is the prevalence of sexual dysfunction among MPN patients? What could be the potential causes for sexual dysfunction among MPN patients, and what are the treatment options? So basically, what I just want to start with is that I take care of a lot of cancer survivors in my practice. And the population of cancer survivors in the United States is growing very rapidly. So in 2016, the number of cancer survivors was estimated to be 15.5 million. But with the aging population, and thank goodness for the advances in early detection and improved treatment methods, the number of cancer survivors is expected to reach 20 million by 2026. So there are a lot of us cancer survivors out there. And it's an area, we are a special subset of patients who have some specific issues that need some TLC. So sexual health is an important part of our identity as an adult. There's no doubt about it. And our sexual health can directly impact our self-esteem and our happiness. And unfortunately, sexual dysfunction can negatively impact the quality of life for cancer survivors. I see that on a daily basis. In general, when we look at women, whether they've had cancer or not, about 80% of women report some decline in sexual desire during menopause. So it happens to the vast majority of women. And menopause brings about a whole variety of changes hormonally and psychologically and physically. But 84% of menopausal women did say that maintaining an active sex life is still very, very important. So it is, we as gynecologists and other healthcare providers are charged with this mission to help improve sexual health for patients of all ages, especially patients who've had cancer. More than 60% of people treated for cancer have long-term sexual dysfunction. So it's incredibly prevalent. What's sad, though, is that fewer than 25% of those with sexual problems get help from a health professional. And so I'm here to try to help give you some pointers as to how you can get the help that you may need. Dr. Mesa was part of a study in 2016 that was the MPN Quality of Life study. And this was a really, really interesting study for me because at the time as an MPN patient, I found this fascinating to read about. But as a physician, I find it equally fascinating. And that what they found is that 2/3 or 64% of patients with MPNs have some degree of sexual dysfunction. And what is even more interesting is that 43% of MPN patients reported those sexual dysfunction symptoms as severe. So that's pretty significant in my opinion. And this study was really, really interesting. It involved almost 2,000 patients, so it was 1,971 patients. You can see the breakdown. 827 of the patients had ET, 682 had PV, 456 had MF, and then there were 6 unclassifieds or other. A little over half were 60 years old and older, and 53% of the patients in this study were female. What the researchers asked of the people in this study is that they wanted to have the patients rank their symptom burden with sexual dysfunction on a scale of 0 to 10. And what they found was that the average score of the sexual dysfunction among these patients was 3.6, which the authors categorized as moderately high symptom burden. And almost 11% of the patients in this study rated their burden, their sexual dysfunction burden, as severe, or they gave it a 10 out of 10. When they broke it down even further, what they found is that the degree of sexual dysfunction was dependent on the type of MPN that the patients had. So patients with myelofibrosis had the most problematic sexuality scores at 4.38, followed by those patients with polycythemia vera, and lastly were the patients with essential thrombocythemia. They took it one step further and they looked at laboratory abnormalities and whether or not they had any correlation with sexual dysfunction scores. And they did. And what they found is that patients who were transfusion dependent had worse sexuality scores than patients who simply had anemia or thrombocytopenia, low platelets, or leukopenia, decreased white count. So the transfusion dependent patients were bothered the most with sexual dysfunction. And they also looked at modality of treatment and whether or not the treatment that the patients were on for their MPN had any impact on their sexual dysfunction score. And they did find that patients who were steroid dependent had the highest degree of sexual dysfunction compared to those on immunomodulators like thalidomide and lenalidomide. And then the ones that were the patients that were the least bothered from a sexual dysfunction standpoint were the patients on interferon. They had the lowest sexual dysfunction score. Another really interesting study that was along the same lines as the study I just talked about was a study done, it was a Danish study, it was in Denmark, and it looked at 2,228 patients. And it also looked at the patient's health-related quality of life among patients with an MPN. The mean age of the patients in this study was 71. 57% of the patients in the study were female. And you can see the breakdown. 814 had ET, 910 had PV. There were 83 with myelofibrosis, and 421 were in the MPN unclassifiable group. And what they found is, again, patients with myelofibrosis had the highest degree of sexual dysfunction with a score of 82%. Those with PV came next, and then the least bothered, but close to the PV score, were those with essential thrombocythemia or the MPN unclassified group. So this study just basically corroborated what Dr. Mesa's study had found. So when we think about MPNs, why is there a significant degree of sexual dysfunction? Well, I think it's multifactorial. And there's no doubt, we've heard today over and over that MPNs are associated with high levels of inflammation. And these high levels of inflammation can definitely have a negative impact on our sexual health. MPN patients have a unique symptom burden. Again, we've heard over and over about how MPN patients can be bothered with fatigue, and it can be severe. MPN patients are also bothered with anxiety and depression, other symptoms such as the chronic itching or the pruritus, and insomnia. And all of these symptoms, the symptom burden, again, has this negative impact on our well-being, on our feelings of sexuality, and it definitely has kind of like this snowball effect. Patients with MPNs may have a poor body image, whether that's because of treatment-related side effects, weight gain, weight loss, For me, it was when I had my transplant and I lost my hair. And so our body image can change significantly because of the disease that we have. And there may be treatment-related side effects. So the medications that we're on for our MPN may very much have an impact on our sexual health. When we talk about female sexual dysfunction, what exactly does it include? Well, it's basically broken down into 4 discrete categories. It includes inhibited sexual desire or decreased libido, inability to become aroused. There may be problems with orgasm, delayed or absent orgasm. And then another category that I see a lot of in my practice is painful intercourse or dyspareunia. So all of these factors are included under the umbrella of female sexual dysfunction. So what are the factors that influence a woman's level of interest in sex? And there are many. We all know that. As we get older or after we've had children, there can be bladder control problems, and this can negatively impact our sexual health or our confidence to have intercourse. Menopause and hormonal changes are huge among my practice and among women in general. We see a lot of this overlap between MPN patients and menopause and hormonal changes. And so the changes that we may see that affect our body because of menopause have a significant impact on our level of interest in sex and our ability to have sex. Sleep disturbance can play a large factor. Depression or anxiety or our mental health in general. Stress, and let's face it, we as MPN patients, we have plenty of that. Medications, and health concerns. And when you look at this list, many of these factors coexist in patients just because they have an MPN. So, MPN patients, again, make up this unique kind of population of patients who are almost set up to have a lot of these factors that may sabotage our sexual health. But we can overcome it, and we'll talk about that. So mood disorders are prevalent in MPN patients. And when I talk about mood disorders, I'm talking mainly about anxiety and depression. And we do know that our mood affects our sexual health. A study from 2019 showed that 21% of MPN patients suffer from anxiety, 12% suffer from depression, and 8% of MPN patients suffer from both. So we cannot ignore this factor when we're counseling our patients about sexual health. And I truly do think of it as kind of this vicious circle, because the more symptom burden and fatigue that we have because of our MPN can lead to a higher degree of sexual dysfunction. And then that can then lead to higher levels of anxiety and depression, and then it circles back around. So this just reminds me that we need to address sexual health among MPN patients in a way that is absolutely inclusive of looking at not only sex itself, but our mood, our mental health, what is going on a deeper level with our patients. We do know that pain among MPN patients can be significant, and pain can be a negative factor when it comes to our sexual health. There was a study out of 2018 that showed that more than half of patients with MPNs report feeling pain that was related to their disease. And the pain may come in the form of abdominal discomfort. 53% of MPN patients reported that. That could be from splenic enlargement or side effects from medications. Bone pain was reported in 48.5% of MPN patients. So in addition to our mental health, we do have to remember to think about whether or not our MPN patients are living with pain on a daily basis and what we can do about that to then help them in terms of their sexual health. Pain can also be specific to the in regards to just painful intercourse, or when sex becomes painful, that is called dyspareunia. And with menopause in general, there's a decreased production of our hormone called estrogen. And estrogen is the hormone that is so important in keeping our vaginal tissues healthy and moist and lubricated. And it helps prevent the pain that can come from with intercourse that's associated with menopause. So 64% of women do experience some degree of painful sex, and that is related to the hormonal changes. The women that do report painful intercourse, in a study that was done of nearly 1,900 women, this study called the Empower Survey, found that 55% of women with painful intercourse rated the pain as moderate to severe. So not even a small amount of pain, but a moderate to severe amount of pain that could be preventing them from being able to have intercourse at all. So even though we're talking specifically about MPN patients, we have to remember that MPN patients go through menopause, and that adds an additional layer of complexity to the problem. So let's think about now how we're going to treat it. We know what it is. We know what it can encompass. How are we going to treat it? And the greatest advice that I can say is that it involves a team of practitioners. It involves your women's healthcare specialist or your gynecologist, the physician taking care of your MPN. This may also involve your primary care physician or even a pelvic physical therapist, but I'll go through that and we'll talk about why it is kind of a very interconnected approach in taking care of these patients. First of all, the first thing that I start with when I counsel my patients about sexual dysfunction is I educate my patient. We just start with basic education about human anatomy and normal sexual function and the normal changes of aging and what she may expect depending on where she is in her childbearing years, where she is in regards to menopause. We talk about her lifestyle. Again, we've heard over and over today how important lifestyle is for MPN patients, and I'm going to echo that. Lifestyle is huge. So we educate about exercise and limiting alcohol, as that may negatively impact our sexual function. We talk about date nights and setting aside time with our partner to truly be present, to be able to enjoy each other and not just, be so caught up in our day-to-day activities that we forget about the importance of that connectivity with our partner. Again, lifestyle changes. My practice is, like I said, a gynecology practice, but it also includes an enormous amount of lifestyle medicine and wellness. I have a registered dietitian on our staff. So we spend a lot of time with our patients talking about how to optimize diet, not only for just wellness in general, but how diet can have an impact on our sexual health, the importance of exercise, and the importance of relaxation. I do try to encourage non-coital behaviors before just jumping right into intercourse, because massage and foreplay are so important to kind of get us in the mood. And most people, unfortunately, dive right into sex, but we do know that an adequate amount of foreplay is crucial for building sex drive and the sexual response. And sometimes as we get older, 15 to 20 minutes of foreplay is not enough. So again, it's just basically trying to educate patients about how their body is changing or how they may need to adapt. Minimizing pain is huge, like I had mentioned. And with this, I'm talking specifically about the pain with intercourse that can happen. So we're going to talk a little bit about the use of vaginal lubricants and moisturizers and how to find the right one, because there's a million of them out there. Some patients may even need to incorporate the use of vaginal dilators, especially if they have not been able to have penetrative intercourse for a while. And we also include our pelvic physical therapy colleagues, because for women who have had months and months or years of painful intercourse, those vaginal muscles remember that pain. And that muscle memory, no matter how relaxed the patient may be, that muscle memory is going to trump that relaxation a lot of times. And so sometimes it involves retraining those pelvic muscles to be able to relax, to be able to have intercourse that is comfortable and pleasurable. And lastly, we do use prescription medications when indicated for sexual dysfunction, and we'll talk about those as well. So in order to be able to treat it, we have to be able to talk about it. And 74% of long-term cancer survivors, female cancer survivors, believe that physicians should regularly ask about sexual issues. But 64% of the patients state that physicians never initiate that conversation during the care. And we get it, I get it. Oncologists and our hematologists and our MPN specialists are incredibly busy. They are just in the trenches day in and day out. And so that visit with them, that time with them, there's so many things to talk about, right? Like your blood counts, when you need your next phlebotomy, how are the side effects from your medications going, so on and so forth. Believe me, I've been there. I was an MPN patient for 10 years. I get it. So this slide is just to remind you that it is okay to initiate that conversation with your physician. And specifically, you definitely lean on the knowledge of your MPN specialist, but also don't forget your gynecologist or your women's health specialist, because we're in this fight with you. We are here to help you, and we will collaborate with your MPN specialist. So the main reason that the oncologist in this study felt that they weren't able to take a good sexual history among the patients was just insufficient time. So again, like I said, the visits with our MPN specialists may not be the visits where we're going to iron out how to fix our sexual dysfunction. And that's where, again, it takes a team. Addressing psychosocial stressors is important for improvement in sexual dysfunction. And so, like I said, your gynecologist or female health specialist is a wonderful place to start to address this. And he or she may involve the use of some psychological therapy or sex therapists as well, because it's sometimes sexual dysfunction is so deep-seated, and it's not only physical. There can be some very kind of deep-seated complex medical issues that have taken hold and are impacting sexual health. And just remembering that it's okay to use these specialists if we need them, because they are wonderful at what they do. So in an ideal world, the oncology team could or should initiate discussions of sexuality and cancer treatment during planning and at follow-up visits. And if they don't initiate that conversation, like I said, take 2 seconds and just say, hey, doc, I have a question. Could you help me with this, or could you steer me in the right direction as it pertains to my sexual health? Like I said, psychosocial and medical assessment should take place when a concern or problem is identified. And referrals can be made, again, for this multidisciplinary treatment team, because again, it's not always physical. There may be some psychosocial issues at play. So now we're going to kind of just jump gears and kind of hit the nitty-gritty real quickly about how these are practical, very practical tips, how you can minimize pain with intercourse. And this topic of vaginal lubricants or vaginal moisturizers is such a complex topic because it's confusing, because there's a bajillion different brands and types and flavors and heated and all of these things. And so it becomes overwhelming, but I'm going to make it very simple for you. There's 2 different types of lubricants, 2 main types. One large category are water-based and the other are silicone-based. They're both good to use. They both have pluses and minuses. But the water-based, those are the ones that are the most common ones that you'll see, like Astroglide or KY jelly. You've probably heard of that. That is water-based. But what we've kind of grown up accustomed to are not always the best ones to use, because there's this issue of what we call osmolality, which I'm not going to make this scientific, but the higher the osmolality lubricant, the worse it is. And KY, and again, I'm not trying to like shame any brands, but I'm just trying to give you some practical advice. You want to stick with a lower osmolality water-based lubricant. And these are some of the brands that fall into that category. And if you can't find them at the store, you can find them online. Silicone-based tend to last a little longer than water-based. So sometimes patients find that the silicone-based lubricants are a little bit more effective at eliminating that friction and the pain associated with intercourse. And this brand, Pension Premium, has been one that has been ranked highly in independent studies. Some patients will stick with something more either affordable, or maybe they have it in their medicine cabinet at home. Some things like vitamin E oil or organic coconut oil, those are fine to use as long as you don't have an allergy to coconut. Some patients will find that they can be a little bit messy, the oil-based lubricants, but again, it's truly just finding which one works for you and that you feel most comfortable with. When vaginal lubricants when that is not enough to restore the moisture in the vagina, a lot of times I'll counsel my patients about using vaginal estrogen. You know, MPN patients, female MPN patients are up against a lot of conflicting information about hormone replacement therapy. And in general, I agree that avoiding systemic hormones can be very wise in MPN patients just because of the increased risk of blood clots and stroke that can occur with systemic hormone replacement. So when we want to target the use of estrogen vaginally, it becomes a very safe modality for our MPN patients, and it's very effective as well. And using estrogen vaginally does not increase the risk of blood clots or stroke. And there are different ways to add back estrogen to the vagina. It can be added back in a tablet, a ring that can, estrogen releasing ring that can stay in the vagina for 3 months at a time, or it can be added back in the form of a cream. And they all have their pluses and minuses. These are all prescription medications that you would obtain from your healthcare provider. And they all work a little bit differently, but have the same concept of when we replace estrogen in our vagina, we improve the moisture, elasticity, and collagen of the vagina so that the vagina becomes more like it was prior to menopause. There's another option that is not an estrogen replacement. It's vaginal DHEA. You may have heard of it, Intrarosa or Prosterone. It's a suppository of this hormone called DHEA that once it's in the body, once it's in the vagina, converts to both estrogen and testosterone. It's just a different option. And so I bring it up just because some of the listeners today may have heard of it or may even be on it. Again, it can be a little bit confusing in terms of the right types of estrogen to use and the types of moisturizers or lubricants that we use in our vagina. And I bring this resource up only because it's an excellent book written by a gynecologist at Northwestern in Chicago. I have no financial interest in this book whatsoever, but it's called Slip Sliding Away. It is an absolutely hilarious, easy to read book that covers everything about a painful intercourse, vaginal vulvar dryness, itching, burning, urinary tract infections, you name it, it covers it in a way that's so easy for patients to understand. And I often recommend this to my patients as a way to just kind of help them educate themselves about this topic. I mentioned pelvic floor physical therapy as a way to eliminate or minimize pain with intercourse. And again, many of you patients may have already used this modality. It is a very effective way to help kind of rehabilitate the pelvic floor or the pelvic floor musculature system. So that way we can engage in intercourse that is not painful. And your gynecologist or your female health specialist will be able to tell you if he or she feels that that is an important part of your therapy. Do not shy away from it. An excellent pelvic physical therapist is worth their weight in gold. Lastly, as I wrap this up, I do think it's important that we touch on lifestyle, because the benefits of being present, or what we call this mindfulness, is so important for so many symptoms that among cancer patients, especially in MPN patients. And there was a study done in the Journal of Sex Research that showed that mindfulness-based therapy did improve sex drive in women. And it also is very effective in reducing stress hormones, which we know have a negative impact on our libido. And all aspects of sexual function and sexual well-being exhibited significant improvement during mindfulness-based therapy. You can ask your physician or your healthcare provider about mindfulness-based therapy. There are several apps that make it very easy as well, but don't overlook the power of mindfulness-based therapies for our mental health, but also as it kind of pours over into our sexual health. As we continue to talk about lifestyle and wellness, there was a very interesting study that looked at body mass index and symptom burden among MPN patients. And I do share this with the MPN patients that I take care of, as well as my cancer patients in general. Among many MPN-related symptoms, including sexual dysfunction, there was a higher degree of symptom burden among obese MPN patients compared to those of normal weight. And this most likely is related to the fact that not always, but often we see higher inflammatory levels among obese patients. So 71% of obese MPN patients reported sexual problems compared to 62.7% of normal weight MPN patients. And I would say that if we're talking about sexual dysfunction, and specifically in this slide, but if we look at joint pain, if we look at fatigue, if we look at other symptoms as well among MPN patients, I would have to venture to say that obesity probably has a significant impact on these other symptoms as well. So I always try to have a discussion about lifestyle and with my patients and how that pertains to healthy eating. I'm a huge fan of educating my patients about nutrition. I had the distinct honor of spending 2 years with Dr. MD-Weill, who's kind of a pioneer in integrative medicine. He taught me an incredible amount of information about wellness, but specifically nutrition. He uses this kind of anti-inflammatory food pyramid that I think is really helpful for MPN patients, because remember, inflammation drives MPNs. And the gist of this pyramid is basically the more vegetables and fruits that you can incorporate into the diet, the more colors of the rainbow that you eat, the less processed that you eat, the greater you're going to be nutritionally, because your inflammation levels are going to diminish. So I try to encourage patients. I go over this food pyramid with them, and we talk about just how important food is. It's not just calories in, it's information that's talking directly to your DNA. So I take it very seriously, and I really try to make sure that my patients have a good grasp of what healthy nutrition means. Lastly, exercise. I cannot stress how important exercise is for everything, including sexual function. We know that exercise improves sexual arousal. It enhances our sexual satisfaction. It improves our body image. and it helps to improve blood flow and circulation. And we've already learned that in that excellent talk that we had earlier today. It doesn't have to be high impact exercise, as we've already learned. This was a small study of 48 MPN patients, but I loved it because it was a study that looked at yoga and the effects, the beneficial effects that yoga can have on MPN symptom burden. And what it showed was 75% of MPN patients felt that yoga was very helpful in coping with their MPN symptoms. Yoga can improve the symptoms of depression and anxiety, which we've already seen can be very common among MPN patients. Yoga can help improve fatigue, and it can help improve our sleep. And one thing that I found just so awesome was that yoga reduces the levels of TNF alpha, which is an inflammatory marker. So yoga can reduce our inflammatory burden. So again, you don't have to be, you don't have to be a triathlete in terms of the amount of exercise to do to decrease the symptom burden. Again, it takes a team. I can't stress on the importance of that enough. Most of the ways that we make sex better is by communicating, right? So don't be afraid to speak up, communicate, be your own advocate, go to bat for yourself and your partner and say, hey, doc, look, I need some help. I'm struggling with this. Eat well, exercise regularly, try to get a good night's sleep. Another thing I tell my patients is let go of the way it used to be. None of us are the same person that we were yesterday. We're not going to be the same person tomorrow, but let go of the way sex used to be. Just adapt, make it playful, be willing to experiment. Your partner's getting older just like you. And so, you're in this together, and there's always a way to make better sex.